Okay, folks, this is Alex Mohseni, and today I'm super excited to talk to Dr. Larry Brilliant here. He's had an amazing career with multiple leadership and executive roles, both within emergency medicine groups and in the hospital environment. So, Larry, welcome. Great to connect with you.
Thanks, Alex. Thanks for having me.
So, I think it'd be awesome to first hear just the general arc of your career story. Where'd you do residency, and then how did your whole career progress, and we can go from there.
Sure. So I am an emergency physician. I am from New York originally. I went to medical school in Stony Brook. I did my emergency medicine residency at the Medical Center Delaware, the Christiana program. Did my first administrative job 2 years out of residency. I got a medical directorship in the Philadelphia area, and I spent most of my clinical career as well as administrative career in the Philadelphia region. Stayed 5 years at academics at a hospital in Center City, Philly as the director, and then moved up to Bucks County to a private group. So I spent 15 years as part of leadership, both on the medical side as well as the administrative side, in an independent emergency medicine group in the Bucks County outside of Philadelphia. Left there and went to a large emergency medicine program, large hospital, 400-bed trauma center in 2015. And that's where my career changed a little. So I started as the medical director, but quickly became the chief medical officer of the institution, and then also became the president of the hospital. It was a 5-hospital system associated with a larger system. When I was CMO, the CEO of my hospital was promoted to the CEO of the entire Mid-Atlantic region, and they were looking to hire a new president for the local hospital. So that was something that I took over and spent a couple of years doing that. It was great for the institution to have an emergency medicine physician leading the facility during COVID. I mean, we got a lot of curveballs and the medical stuff, so it really helped to have a physician in the leadership role as we went through that. There was a restructure back in 2022. I left that job and came to Team Health, where I am now a regional medical director. I did go back to clinical. I hadn't done clinical in several years, missed it. So went back. I am faculty now at emergency medicine residency. I also work at a very busy hospital in New Jersey doing clinical on my own. With a Team Health contract, and that's pretty much my story. I also did an MBA. So right before when I was chief medical officer, and I know we could talk about this. I went back and forth. Do I want to do the CPE program, which I did, or go for the MBA? So I ended up doing both. So got an MBA in the University of Massachusetts, and that's where I am today.
Amazing. So let's go back to the origin story. So do you remember when you were first 100% clinical, and then when the first opportunity came to have some sort of leadership role, what was the story there? How did you even, have that opportunity or create that opportunity? And what was going in your mind at that time when you were deciding whether to do that or not?
I think a lot of it has to come down to mentorship. So both for my first and my second clinical opportunity, there were chief medical officers who kind of looked at me and said, you got the talent, you have the passion, you want to do this, let me help you make this happen. So at the first job, I was made chairman of the credentials committee, the bylaws committee. Anytime there was any kind of project, they would ask me to participate, and of course you say yes. I've always said, make yourself indispensable to an institution and don't say no. And they guide you through that and you learn. And the same thing at my next job. The CMO saw that there was someone here who was interested in doing the work, had done the work. And as you become more and more successful, you take over more and more jobs. They kind of groom you into that next position.
Yeah, I think that's definitely a theme that we hear with many other successful physician executives is early in their career, they said yes to, pretty much everything, every opportunity to provide value, to take on a project, to solve a problem. So that's really awesome. And then, so you mentioned you worked in a hospital in Center City. Which hospital was that?
It was Episcopal Hospital, which no longer It's there. It used to be, they did the first cardiac surgery in Philadelphia, was done at this hospital.
Oh,
Very busy cardiac center. It was part of the Temple Health System, and as Temple did their consolidations, it is still open, but I think now it's a kind of like it's freestanding ED with 10 beds, and everything else is transferred back to the mothership.
I worked at, I did my residency at Jefferson, and we would rotate at Methodist Hospital.
Yes.
In South Philly. And I have so many stories from that hospital that probably not appropriate for this conversation. So as your career progressed, how did you feel in terms of whether you understood the business of medicine and all the stuff that like they didn't teach us in medical school? Like what triggered you to get the MBA and the CPE? Like, I presume like you could tell there was a lot more that you wanted to learn.
So a lot of this, you're right, was not taught in medical school. And I give this next lecture now. I do have a couple of emergency medicine residencies in my portfolio. And I give this lecture, and it's the most well-attended lecture. Give it every year, because every year as a resident progresses, it means something different. Yeah. What's an RVU? What's malpractice insurance? What's claims made? There's so many things that were not taught that we're trying to bring into the curriculum of the residents, so when they come out, they can make an educated decision. So I think that is the first part of it. I did go to a lecture once and did have a conversation with a couple of CMOs and said, do I need a CPE? Do I need an MBA? What is next in the progression? And I think what I took away was, if you want to become a medical director or a CMO, you're good. You can do it in what you're doing, and the CPE may help as part of that. Yeah. If you want to move on and become a president or a CEO or some leadership in a larger group, the MBA definitely helps. I'm sorry, helps. Yeah. But I think we did it differently. So at least when I went into it, I was working with spreadsheets and balance sheets and understanding margin concepts and finance, never having the formal training. I never took it in college. So for me, I had done it. I was comfortable. And then the theory after it kind of added a different perspective to it, as opposed to a lot of the MBAs who are coming into management roles. They get the theory and then they learn the practical after. So I think it helped, but I don't think it helped to an extent that it would have if I had never done it before. I think it solidifies what you're doing, but you need the titles if you want to go into some of these advanced roles. In order to become a differentiated person, you do need the titles.
Larry, talk to me about what additional things did you have to learn, especially, I guess, from the business and strategic perspective, in order to transition from a medical director type role to more of a like regional executive, and then eventually even to a hospital executive?
Yeah, I think for me, it was the finance. I didn't have a strong handle on the finance. I could walk into any department meeting and I could talk medicine. But when I walked into the finance meeting and looked at all the spreadsheets and, just to be very comfortable in Excel, that's where I needed the formal training. That's where it really helped. And the way I look at it, I talk about it, is I could do a 360. I've worked as a pit doc. I've worked as a medical director. I've worked as a CMO. I've worked as a president. I've worked in independent groups. I've worked in private groups. I've worked in university settings, just to be able to look at all different perspectives. And I think as a physician walking in, you could speak to physicians. You could also speak, when you know the finance language, to the finance folks. Right. So to be able to be comfortable, whether you're in the boardroom or be in your scrubs in the ED, or wherever your clinical site is. Yeah. So I think it just added a little more street cred to me to be able to speak the language like they speak it and to understand it. Because how many times have you been in a meeting where the finance people like want to trip you up and they show you all the spreadsheets and they want to seem really smart? And it's just time to say, slow down. I got you. I speak this language too.
Yeah, amazing. Tell me, what is the difference between a CMO of a hospital and the president of a hospital in terms of their roles, and whose interests they're representing?
So the CEO is responsible for everything that goes on at an institution. And they report directly to the board of directors. So the board of directors is responsible for all the safety to make sure everything is running financially well for the entire institution. So the CEO reports directly to the board. The medical staff also reports up to the board, usually during a different pathway. The CMO kind of sits between the board, the CEO, and the medical staff and nursing. All the clinical activities of the institution report up through the CMO. So you're kind of the intermediary between the medical staff and the board.
So, and you at some point were both, at some point you were the CMO of your health system, and at a different point you were also the president of the medical staff?
No, the president of the hospital.
Oh, president of the hospital, not president of the medical. Got it.
So the president of the medical staff reports is really elected just to support the medical staff. So I sat as the president, this chief medical officer of the hospital, as well as the president of the hospital. Because we're part of a 5-hospital system, there was a president in each of the 5 hospitals that reported up to a regional chief executive officer.
Right.
So but I essentially was the chief executive officer at that particular site, responsible for everything that went on at the hospital.
Yeah. And make sure I understand. So prior to that, you were in an executive role at Team Health. Is that correct?
I was a medical director at Team
Medical
Health.
director. I mean, that's a very prestigious jump to make from a medical director of a contractor group, right, to then an executive for the health system itself. Not
the health system, but within the hospital.
Sorry, the hospital, but still.
Yeah, it was a privilege. And again,
it was amazing.
Showing up and getting support of the medical staff. So when it became time for chief medical officer, the medical staff had to support the recommendation of the CEO at the time for who was going to be in that position. And it was a privilege to be able to be recommended. And of course, the doctors wanted a doctor in that position in order to do it. But we could talk for hours. It's a tough position.
Yeah.
Dealing with your peers. And I was in a little different situation because I was still practicing emergency medicine. So I had a clinical relationship with a physician. And I'll tell you, the stories where someone is yelling at me because of an administrative conflict, but then 2 o'clock in the morning when I'm taking care of their patient, I'm their best friend.
Yeah.
It was kind of, and there was one cardiologist at a very large medical staff meeting who was screaming, like yelling. We were making some changes. And then he turned to me and in front of everyone and said, "Larry, I'm so sorry." But then he continued to yell. So it's how do you leverage all those relationships and do what you feel is right? You have to do what you think is right.
Yeah.
If you're told to do something, you're not going to do it unless you feel it's right. You'll push back.
Yeah.
You may be forced into some decisions, but no one's forcing you to do it unless you really you believe it makes sense.
What did you like most about being an executive at the hospital? And what were some of the biggest challenges in that role?
I loved when we were able to expand. I loved when we were able to bring in new services. That was the great things. I loved working with the physicians, where a physician would come in and say, "Can we do this? We want to start doing some kind of fancy invasive catheter. How do we do it? Let's talk. Let's get together. Let's get the cost. Let's put together a business plan. See what the costs are going to be and see what the reality of working it through. And able to bring new services, fantastic. What I did not like is there are sometimes physicians who are not the best citizens, or patient or doctors who are having some peer review issues. And how do you navigate through that? I saved many careers. Docs who were having issues, who were able to come to the table, walk through their issues, and change their lives in many, many ways. We could talk about that in the future also. How you do that, how you engage those docs to make those decisions is really strong. What I didn't like was, and this was extremely, after COVID, it was very difficult because volumes dropped precipitously. Financing dropped and changed precipitously. It was a whole different world. Now, staff that you've worked with for years, you have to look at and say, who do you let go? When you do force reductions, when you do a RIF, those are really, really tough decisions that you have to navigate through. But you you have to make money. You have to at least break even in order to be able to continue to exist. Hospitals in the past, margins 12, 14%. Operating at a 12 to 14% margin is fantastic.
Yeah.
How do you operate at a minus 1% margin?
Yeah.
What services, and bringing the medical staff into part of those decisions was important as we made some decisions, but sometimes you couldn't because they were very difficult. So that's probably the most difficult part of that. And you watch the news today, hospitals are closing.
Yeah.
Hospitals are reducing a significant part of their non-patient front-facing staff, which means administration.
Yeah. Larry, how much, when you look back at this kind of amazing career arc you've had, how much of it would you attribute to luck versus you putting in the elbow grease to really, take on projects, say yes to everything, and increasing your surface area for opportunities?
That's a great question. I think some of it is you. It's the person. If you don't have pieces that are going to make you an executive, it's not going to work out. But there is some luck being at a place where they didn't have someone. I had only been there for 2.5 years at the time for them to make you a chief medical officer. I mean, that's pretty impressive when you would think we had a medical staff of about 700 or 800 doctors and 200 APPs. So there was over 1,000 people on the medical staff. So, only one of them can become your chief medical officer moving forward. I got lucky that I had a new CEO who liked me, who we had a really good relationship, who would call me for difficult conversations. So part of that, if you're going to call it luck, is luck, that I had that type of leader who was willing to support me as we move through. So I think it's a mixture of both.
Larry, talk to me about how your interpersonal relationships evolved as you progressed through these various roles, especially from the perspective of going from a doc in the pit where the bonds with the fellow providers are very strong. And then as you progress up the chain, you realize that certain things that docs want, for example, from a financial perspective, simply can't happen, right? Like it doesn't make sense. And now I know that I really struggled with this sort of, the conflict inside of me where I truly believe and understand what the pit doctors are begging for, but I also understand from the hospital leadership perspective, like this is never going to work, right? And how do you resolve that? So like, tell us, maybe share some insights about how you dealt with those sort of feelings.
Yeah, you nailed it because you've lived it. And when you have to cut back hours or cut back a service or close a service, the effect it has on the physicians.
Yeah.
And the biggest thing for me is discussing the why. Why are we doing it? Look at alternatives. If you can come up with an alternative, let's discuss it. But how else do I get it? Right. If you're able to walk it through, with the why behind it, that's how it makes sense. Yes, it affects people. Yes, it affects your bottom line. Yes, it affects your doc's dollars, but it's the why. And I think that's a big part, having them understand your side as well as their side and listening.
Yeah. Tell me, what did you feel like the CPE gave you that the MBA did not?
MBA gave me more of the finance. It was a more in-depth, where the CPA, you did a quick finance, but it wasn't doing projects where you were able to work with your other MBA students and work together like you do in real life. You're not going to do anything in a silo.
Yeah.
It's something that you do with groups. So it's a much more in-depth on the finance, on the negotiation side of it, on the marketing. I'd never taken a marketing class. On the accounting side. Mm-hmm. I didn't take accounting in college. So it was just going into a more depth, and mine was healthcare related. So I was able to do projects in that direction. What I liked about the CPA was the ability to interact with other folks like us. When you do your capstone at the end, there's role playing, the ability to go through these difficult situations and to role play through them. I think those are the biggest things that you could do.
Got it. Okay, so Larry, I guess my last question: what would you tell folks who are maybe early in their career and they want to lay the groundwork for some sort of leadership, executive role. Like, what would be the one or two pointers you would tell these sort of folks?
You got to love what you do. The grass ain't greener elsewhere. So unfortunately, I know physicians who struggled, they burnt out in their clinical careers, went into an administrative career, they burnt out too. So you have to make sure you know what you're getting yourself into and do what you love. I was at a course for burnout, and there was a doctor next to me who stood up in front of a whole audience and started yelling at me also, because I was the CMO at the time, we can't do this anymore. How do you expect me to do my concierge service, my home health care, my nursing homes, hospital work, and offices, and still sign charts on time? Can't. You can't do everything. So I think you need to look at what makes you happy and what you want to do. And if you give up your nursing home practice, or you give up your inpatient practice, and you knock off, maybe you make 10, 20% less, but you have more bandwidth to do what you enjoy. I think it's important for them to make time for yourself. I would make sure I went to the gym 2 nights a week. I had a 5:30 meeting in my calendar.
Yeah.
5:30, my administrative assistant would keep that sacred. She laughed because she knew where I was going.
Yeah.
But 5:45, I would get to class, twice a week. So make time for yourself, just to make sure it doesn't interfere, and just be realistic about what you're going to do. You have to, there's always conflict. There's always tough decisions that need to be made, no matter what level you're in. But you have to do it, and you have to do it because you feel it's right and something you're not being told to do. You got to understand the why.
Amazing. Well, Larry, brilliant. Thank you so much. This was really lovely to hear your story and the journey that you took, and I hope we can all learn from it. So thank you again.